Welcome back, everybody, to Medical Testimony Master Class. And you'll recall it's a forum where we're going to critique the testimony of medical experts in high-stakes, complex litigation, whether it's medical negligence or personal injury. We're going to cover it all. We're going to see what works. We're going to avoid obvious pitfalls and really build best practices for working with medical experts at trial. And you are in for a treat today because we're going to be watching excerpts from a trial by a very skilled, well-known trial attorney. Most of you will know his name, Sean Claggett of Claggett and Sykes out of Las Vegas. So Sean has got quite a trial that he's prevailed with a $14.1 million verdict. And it's called Roybal, R-O-Y-B-A-L, v. Bellamo. It basically involves a Nevada trial for a bicyclist who was run over by an SUV driven by an employee of a local business. So the plaintiff contends that he's sustained a number of injuries to his neck and shoulder and chest. And what we're going to be delving into on this clip is Sean's direct examination of Dr. Michael Trainer, who is a Nevada orthopedic spine surgeon who actually operated on the plaintiff. So a little different than our typical expert witness. This is the actual treater. But what I think you're going to see is he's acting a lot like a great expert witness and really nails some of the critical points that we'll go through critically. So with that, why don't we get rolling on this clip and let's see what Sean does as we open up cross, and we're starting with, as we open up direct, and we're starting with Dr. Trainer taking us through a video animation.
Here we go. Okay. So again, it's typically performed with the patient on their back, and incisions made on the side of the neck, depending on the level. The C6-7 is just a little above the clavicle or collarbone, so this is a right-sided neck incision. And these are the nerve roots that come off the spinal cord and exit the spinal canal. So C6 vertebrae, C7 vertebrae, here's the disc in the middle, and you can see where the nerves are.
I'm going to pause at that point, and you all have seen a lot of different demonstratives, whether it's videos or photographs. This one's nice for a couple of reasons. First of all, when we're performing surgery on someone's neck and he's about to take us through a cervical discectomy, surgery can be pretty graphic. And I've seen a lot of videos where the scalpel comes in and there's bleeding and they're pulling skin back and they're dissecting through fat. A lot of that can be intimidating to a juror and make them turn their eyes away. So I really like a clean, modern video, 3D animation. Let's avoid the blood and gore. So yes, they had to open the neck to show you where we're going, but they're on to the next scene already. What I also like is that the expert and attorney are working together. So it's not that he's got to keep saying pause or can you back up. He sort of spoke through it. So it looks very well rehearsed. It's got a good cadence with the video itself. So let's go back to Dr. Trainer as he starts to explain not only the underlying injury with the disc, but how he repaired it.
So part of the disc issue, you can pause, yeah, part of the disc issue here is that the cushion's not cushioning, it's collapsed down. And I mean, if you've ever sat on a cushion, you sit on it, it spreads out. Well, if it spreads out and it takes up room where these nerves are, the spinal cord's in the middle, the nerves come off to the right side and the left side. This is the left side on this model. So that nerve could be compressed. If that nerve's compressed, it goes all the way down your arm. And so that's the thought process. That's also been the thought process with the myelogram. If the dye's in there and you see the dye get cut off to the left side at this area, oh, something's pinching.
Look how nice that is again. Dr. Trainer's facing the jury. He's not just talking to Sean Claggett, but he's talking to the jury. They're the decision makers in there on that day. And he's putting it in terms they can understand. And not only that, instead of talking about complex intervertebral disc anatomy and disc extrusion and protrusion and everything else, he equates it to a cushion on a chair. It says if you sit on a cushion on a chair and it bulges out, it's the same thing that happens to a disc that gets squished down. It bulges out and it hurts the nerve that's sitting right there because it gets pressed on. What a great analogy. So whenever you can have an expert take someone through a complex medical process and use simple analogies, it really speaks to a jury. So work with your expert on that. Have them explain what the process is, but then work on different analogies. So whether it's complex regional pain syndrome, which can be incredibly complicated, different types of leukemias and lymphomas that are hard to explain. How can we simplify those and talk about taking a disc into a chair cushion? He's really done a great job. And that's something we often don't see with advanced healthcare providers, spine surgeons and neurosurgeons. But Dr. Trainer's got a great way of approaching the audience. So let's return to him.
And that's the concern. So that's what we're seeing.
You've said that on the left side. I mean, in this case, we know because the jury in opening saw the photos of Thunder, all the damage to him was left-sided damage from the result of this. Is it consistent to you that the trauma to the neck is actually all left-sided, and that's what you saw in the MRI and on
He
the
was
surgery?
on the left side, as I recall.
Yeah.
His head himself is, I mean, again, common sense, it correlates.
Yeah. So the fact that when you go in and
I also like the reference to common sense. It sounds a bit casual and impromptu, but people understand common sense. Sometimes common sense triumphs the facts because we know that people want to understand things in their own terms. So this man happened to have been hurt on his left side, and lo and behold, it's the left side of his neck that's injured, and he has a left-sided bulging disc. It's protruding and hurting left-sided nerves. So what he's saying is it all fits together. I can be pretty certain about that. So again, simplifies and demystifies an issue by couching in terms of common sense.
he's got bruising all over his whole left side, he broke his left scapula, and then you go and look at the CT scan and you're saying, oh geez, look at that, it's left-sided problems. And then when you did the surgery, did you also know that it was left-sided?
Yes.
And that all puts together the in your mind, 100% certainty that this is the right cause of all this.
Yes.
Okay.
So you can continue. So this is just sort of showing the compression. So as a surgeon, we need to clean this up. So discectomy means a removal. So we're going to remove all of that disc tissue. Again, it's not cushioning. It's not serving its job is to separate the vertebrae, and it's actually compressing things. And there were other changes as well, which again, the bone spurs, if the disc wasn't injured, maybe the bone spurs don't ever cause a problem, but they were there, so you don't need them. So this is the animation. Basically, you're removing, and that's what it would look like. So at this point, you can see that there is no compression now because of the disc. There is still some bone spurring, and all this stuff would be, we actually use drills and biters and scrapers, and it's a lot of carpentry, quite frankly, to smooth it out and open it up. Again, as a spine surgeon, I don't fix any nerves. I just make sure they're not pinched anymore. And that's one of the concerns, because, and you can stop the animation there for a moment. Or could you back it up like 5 seconds maybe? If that. Maybe I apologize. Yes, stop there. Yeah. So again, at this point, the disc has been removed, the bone work has been done, the passageways are open. Now, this is the spacer, which in this instance, this is a plastic spacer, but this material inside is the bone. So when we scrape off all those bone spurs with the drill, we also literally drill into the end plates of the bone. The reason we do that is we want to create bleeding bone. Why? Because bleeding bone or injured bone heals. So the surgeon literally wants to drill a little bit into the bone so there's bleeding bone, and then we put the spacer in, and the bone, over it takes about 6 months for fusion to heal. This bone will literally heal across to this bone with this. That's the fusion. Now, The spacer is, again, the structural component that keeps the bone separated while it heals. So when the bone does heal, passageways remain open. And so again, you're not going to compress the nerves. So if that was where the nerves were compressed, the left arm symptoms hopefully will get better unless there's permanent damage. And number two, you're not grinding on a bad cushion anymore.
Okay.
So that's the idea. So this is what the spacer is going to get pushed in, which you can continue the video. And then the last part of it, typically we'll put a plate and screws over the front. Years ago, when we didn't have plates and screws, we would just put a spacer in. It actually used to come from your hip, and patients would complain of that, but the plate and screws locks it in place. Years ago, before we had those, if you had that surgery, you might be in a neck collar for 6 months, but the plate and screws, because it holds things in place, it allows it to heal better. The analogy I give to my patients, it's like if you were a woodworker and you wanted to make furniture, but you didn't want any screws or nails, so you use wood glue, and you put the glue on the wood, you put it together, and you put a clamp on it. The clamp just holds the wood together until the glue sets. Once the glue sets, you take the clamp off, you don't need it anymore. Technically, the plate could come out after 6 months if the bone fused together. We don't typically take the plate out because it's another surgery. So you just leave it. So that's basically what we have.
All right.
So Dr. Trainer's taken a complex construct, discectomy, fusion, temporary spacer plating, and in about 2 minutes really distilled it in very nice, simple terms. The jury now understands, why is this disc causing problems? How do we fix it? What did the patient have to go through? And what I liked, again, is Dr. Trainer's ability to articulate it. Those are all constructs you'll need to understand when you have spinal surgery cases. It's all about the bone, the vertebra, the disc, which is the shock absorber in between, and the nerve roots, and sometimes the spinal cord or spinal fluid. Not that many things there. And so easy for you to be able to look that up, understand the anatomy, and then have a great expert who can take you through it. What I also always admire with Sean, who's just a master in the courtroom, is that there were places where he could have interrupted or asked questions or had the expert expand on an area, but he's playing off the expert's momentum. The expert's got a good cadence. The jury's probably very attentive because these are interesting terms. He's talking about carpentry and cushions and things that are interesting. So rather than interrupting him or saying, Doc, let me have you pause here. Can you go back a minute or explain? Those are things we often see on direct that can just distract or disrupt cadence. I think that they're great to use when a doctor has lost the momentum or is going off target. But when the experts got the courtroom going, there's no point in interrupting with something that isn't really calculated to advance the agenda. So I thought it was a great interplay between both attorney and expert at that point. Let's join again.
Thank you so much. We can go back on the witness stand. Now, Doctor, you talked about, you said a few times that one of the options is you do this surgery and 100% it was compressed, it was causing problems, and you fix it. But the patient still has pain. It's a permanent injury. What do you mean by that?
Well, again, after the surgery, we expect certain things. Sometimes you actually have more irritation. That's why there's a recovery with surgery. The surgery is trauma, obviously. So, and that's why you need pain pills after surgery. But the point being is you certainly expect certain things. The fusion typically takes 6 months to heal. The nerve recovery often takes 6 months to heal, sometimes even longer. The studies tell us that 90% of patients at 6 months, whatever nerve relief they're going to obtain from that surgery, that's what they are going to get. There's about 10% of patients that have nerve recovery up to 1 year after a surgery like this. So after a surgery like this, the possibilities are, number one, the patient's symptoms dramatically improve, which is what you want. And then you don't sort of search for any other issues because they're doing terrific. Number two is they improve, but maybe not as much as you would hope for. So in that instance, it could be because there is some degree of damage, or it could be that maybe we didn't do enough. Maybe there's some area, maybe we needed to do more. That happens. Or the third possibility is, like I say, more permanent damage, and you did the right surgery, it just didn't work. So those are the different possibilities that can happen. And unfortunately, you don't know that right away because you have to give the surgery time to heal.
And in this particular case, you did the surgery on Thunder on April 30th, 2018. Doing the math, it's about a year and a half or so, a little bit more after the wreck. Then you follow up with them for some time. Let's see, how long did you follow up with them for?
I think my last visit was in December, so that was about 7.5 months.
Yeah, that's right. So
after the surgery.
Yep. So
Just a quick interruption there. I love that. So the surgeon knows the records well enough that without even having to look down, gives the date of the last surgery. And that's not difficult to do, but how often do we ask an expert a question? Did you treat the patient? They go, well, let me look at the records again. Let me check. It's just a distraction. And I sometimes find medical experts have hesitancy just answering common sense questions. Doctor, what's your name? Well, let me check. So I really like Dr. Trainer just knew offhand what the last date is. So I guess the point that I'm emphasizing is some cases have thousands of pages of records. We're not going to memorize everything or complex data, but have your expert be comfortable with basic things. What was the date of the ER visit, or when did you last see the patient, or what type of surgery did you perform? They shouldn't always have to reference a record. They should be facile with the information so that they can just relate it, as Dr. Trainer did.
definitely, that's really good memory. December 14th, 2018. So you followed up with them that whole time. Can you explain to us all how Thunder did post-surgery?
Yeah, the surgery went well. We had no complications or problems, but he just had persistence of some symptoms, some persistence of some left arm symptoms, some persistence of some neck pain symptoms, some persistence of some shoulder symptoms. And again, right away, that's not unexpected because as I said, the surgery takes 6 months to heal. And so sometimes patient symptoms are worse at first. So we, follow the patient along and do what we can to try to help that recovery. So things like steroid medication sometimes can help as the nerves are recovering because there's inflammation. We'll do therapies, physical therapy treatments. It's again part of the recovery process. I typically follow these patients for 6 months because by 6 months the fusion should be healed, and we do x-rays as well. If during that time frame we haven't obtained the results that we were anticipating, I typically investigate further, meaning, is there a way that I can find out, is there permanent damage? Did we not do enough? Is there more than one source of these symptoms?
All right, so we'll pause the video and that'll be the end of what we'll be examining in this segment. But what Dr. Trainer's just getting into are potential issues of chronicity or permanency. So one thought from a plaintiff perspective is, well, if you have the surgery and it was perfect and there's no symptoms, the compensable harm is tremendously diminished. By the same token, defense wants to show how successful that a surgery was. So yep, terrible this happened, but thank goodness everything's resolved. So understanding issues with chronicity, permanence, impact on activities of daily living, the extent of recovery. Another point, of course, to get into beyond that is what future things may be required. Is this disc surgery one and done? He'll never need surgery again? Or will he run into issues, sometimes what's called adjacent segment disease, problems at other levels of the spine? Or can this problem return? So all kinds of things that I'm sure are coming up on this direct examination. But in your spine cases, always wanting to talk about that. And in any surgery case, did the surgery fix it? Or are there additional issues, and where might that take us in the future? So I think we've covered a lot of great things today. And again, thank you to Sean Claggett of Claggett and Sykes for doing a great job on direct of Dr. Trainer. And I hope you've learned a few things from this. Spine surgery cases are common, and it's common constructs, whether it's cervical, thoracic, or lumbar spine. So you'd be well advised to learn from a few things that happened today. And I wish you good luck on your next spine surgery case. Thanks for joining this segment of Medical Testimony Masterclass, and we'll look for you on the next one. See ya.